Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki eko weshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
Well, bonjour, bienvenue, hello and welcome everyone. Happy summer. And I'd like to say that today is our last Family Medicine Grand Rounds session of the academic year. We'll be taking a pause in July and August and starting up again in September. And we've got a full slate for the fall. So this is terrific. I would also like to take this time now to introduce our presenter today. It's my privilege to introduce Dr. Alan Ng. I think everybody is very familiar with Alan. He's a clinician-teacher and lead physician for behavioral medicine, the Department of Family Medicine here at the University of Ottawa. He is a clinician educator in the Department of Examinations, Assessment and Certification at the College of Family Physicians, Canada. He's currently based at the Primrose Family Centre. His clinical interests include the consultation in family medicine, Valent groups, and medical humanities and assessment and medical education. I'd also like to say that Alan is a very active member in the family medicine choir. He is a piano accompanist, guitar accompanist extraordinaire, and make a pitch for the family medicine choir, the GAD Sevens. If anybody wants to join, we'll be starting up again in the fall. Alan, I'm going to turn things over to you. So go ahead. Oh, by the way, everybody, I didn't introduce myself. Doug Archibald, Director of Research for the department, and I'll be today's moderator. So sorry, Alan, over to you now.
Right. Thanks for the kind words, Doug. I'm just going to share my screen so I can get this PowerPoint up. Just want to make sure someone can just give me a thumbs up that they can see that.
Perfect, Alan. We see you. You're all set. Yep.
Perfect. Okay, so I'll get started. It's a pleasure to be here and to represent the Primrose unit. I guess it's our turn to present. So I'm going to be talking basically about something which I call the knowledge work of generalism. And because I'm the behavioral medicine lead for the department, I want to sort of illustrate a couple of projects that were done by residents, which deal with and tackle this topic. So I want to just acknowledge briefly the work of Joanne Reeve, who is a academic family doctor in the United Kingdom, who's done a lot of work on generalism and knowledge work in generalism, and many of my thoughts and ideas have come from her work. Also, I'll briefly mention, I will actually mention them more as we go along, Dr. Jonathan Zhang, Dr. Sean To, Dr. Mariella Fleury, and Dr. Leila Badar, because they are the residents that did these two projects. All right, so I have no conflicts of interest. So what are we going to talk about in this short time? This is really about MedEd, medical educations, and the strategies that we are trying to implement to address the curricular goal of producing family docs who are trained in generalist care. So this is really what we're going to be talking about. Stated aim of our program, as you all know, is to train family docs in generalist comprehensive care. Now, medical generalism it's a topic on its own. Essentially, if you had to define it, and there have been lots of attempts to do so, the expertise and practice of whole person medicine. I think that as opposed to specialist medicine, which focuses on conditions or organ-specific care. Sorry, I'm just going to move that Zoom window. Screen. Oops. Okay. So now there is wide-ranging literature and discussion about what actually constitutes medical generalism. I'm not going to go into that at this time. That's a whole talk on its own. But what I will say is that we do need to strengthen whole person generalist healthcare. Our workforce needs to be trained for this very challenging and complex role. And there is a tension between what is taught often in med school. There's the taught paradigm of evidence-based specialist medicine and biomedicine, where we try and fit patients to disease management plans. And the way that we actually work at the coalface as family docs, all of you who are family docs doing this work know that that doesn't often work or is actually challenging to do. So what we are trying to do is deliver tailored advanced generalist care. And we think, family physicians think in a different way as we do that. And the other thing about that is many clinicians describe not having adequate training in this way of thinking. So a key educational priority is to examine what we call the knowledge work of family medicine that defines generalist practice. So knowledge work actually is based on inductive and not deductive reasoning. It involves the creation of knowledge in context rather than the application of an externally defined statement of a disease state. So that's very, very wordy. I will try and explain that a bit better. Knowledge work is essentially the work that clinicians do to find, create, and use knowledge. We often talk about family docs in terms of what we know. We know a little about a lot. You know, we're kind of the jack of all trades. But we actually also have to think about how we use that knowledge, because knowledge workers think for a living and family physicians are knowledge workers. So we have distinct skills, and our expertise lies in how we use that knowledge to provide basically an adaptive response to complex problems. There is this concept, which I find very interesting. I don't know if you're familiar with this, guidelines versus mind lines. Research was done by Gabay and May, which recognizes that this is the generation of practice-based evidence as opposed to evidence-based medicine. So it's what we actually learn as we are with our patients, ideally longitudinally over time, and developing relationships with them. Gabby and May observed coalface family docs in practice, and what they noticed was how we we often, although we do rely on EBM, on evidence-based medicine, we don't access it directly, but we develop our own set of guidelines in the head. And these guidelines come from multiple sources, merged with past experiences, continual learning that we do. And this becomes our internal guide to practicing everyday medicine. So we certainly, as we get more experienced, rely on what are known as, I guess, mind lines, as opposed to guidelines. Now, specialist practice is built on hypodeductive reasoning. And this is actually the way we predominantly think about patients, and it's the way, and disease, and this is modeled for us, in medical school. And hypothetic deductive reasoning gives us an objective sort of in certain starting points. So there's the disease, and specialists, their work is concentrating on working out whether that patient has the disease or not. Generalists, and family physicians are generalists. There are other generalists as well, but generalist practice uses a different approach. It's an exploratory work that comes from trying to understand the whole person illness. And this is an inductive reasoning process to try and explore and generate a whole person understanding. So we, as family docs, working in the community, use inductive reasoning. It's a type of knowledge work. And to do that requires quite a large amount of emotional and intellectual capacity, for which we need adequate time, space, and resources. Now, because we are teachers of family medicine, we have to be able to teach and model that. The other term I'm just going to introduce is, I don't know if you're familiar with this, the wicked problem. The wicked problem is a problem that can't be solved or fixed because there is no one single solution. The situation is constantly changing, and wicked problems, I've got resist twice there, resist, a simple or straightforward solution. And making individually tailored decisions about healthcare needs, which is what we do as family docs, can be seen as a wicked problem, and family medicine is full of wicked problems. And I just think back to my last 2 days in clinic. A number of patients would definitely fit into that category. So back to MedEd. So how are we going to try and teach some of this? And this is not knowledge, this is knowledge work, the way to think about family medicine. So I'm just going to quickly describe the spiral curriculum that we have in behavioral medicine here at U Ottawa. Basically, a spiral curriculum is one where there's either a revisiting of topics throughout the course. So you start with a base, and then you just build on that subsequently on the previous encounters. So sorry, on the previous learning and teaching. The behavioral medicine curriculum is based on that, the base of the family medicine curriculum, the spiral curriculum in behavioral medicine is the consultation. So that's the visit. That's the time that is actually spent with the patient and the doctor. This is the basic sort of unit of what we do. It's our main tool. And then, so the behavioral medicine curriculum is based on that, how to do patient-centered interviewing, how to use a patient-centered approach. And then we build on top of that, because everything goes back to the consultation. So how to do things by telephone, how to do motivational interviewing, how to manage uncertainty, how to manage an angry patient, how to use brief CBT, how to do motivational interviewing, how to handle medically unexplained symptoms, how to deal with borderline patients, trauma-informed care, the difficult patient, childhood and adolescent medicine, narrative medicine, using balance groups, cultural competency, the doctor-patient relationship, visual thinking strategies, using humanities and ethics. So all of these things are actually topics that are taught through the behavioral medicine curriculum, but it's all comes down to this, to the consultation. And the consultation, which is the visit, is an academic subject in its own right. And I'm a bit of a consultation nerd. These are some standard textbooks on this topic. The consultation should be treated like as an academic topic in family medicine teaching, just like diabetes and hypertension and even POCUS. things like that. So, and I have written a commentary about this topic in CFP, which was published last year. Now, the other thing quickly to mention is that family medicine is postmodern. Values of postmodern theory are uncertainty, complexity, nonlinear narratives, different multifaceted descriptions of the truth. And this is essentially what we live with as coal-faced family docs. All right, so the two QI projects I want to just briefly go through. The first one, Dr. Zhang and Dr. Toh, does viewing a feature film in a medical humanities teaching session address curricular goals within a family medicine residency? The second one was done by Dr. Badar and Dr. Fleury. In family medicine residents at the University of Ottawa, do ballot groups lead to increased sense of competence in dealing with difficult patient encounters? And the reason I chose to present these two is actually because both of these projects won resident scholarship awards. They were submitted to a national competition, which is run by the Foundation for Medical Practice Education. It's based in McMaster, and they won. Dr. Toh and Dr. Zhang got second prize, and this is a national competition. U Ottawa had never won any of these before when I look back on. And Dr. Fleury and Dr. Badar actually were the top winners for their project. So that's why I want to share this work with you as well. I supervised both of those projects. So we'll just talk firstly about the first one. Dr. Toh and Dr. Zhang did a project, and the objective was to explore the effectiveness of using film to address curricular goals as part of the U Ottawa Family Medicine Postgraduate Program, and also to provide some feedback to improve and refine our humanities curriculum. It's a QI project. The film that was shown, I don't know, many of you have probably seen this. It's a semi-autobiographical film. It's about basically a character grappling with the knowledge that her grandmother has been diagnosed with stage 4 cancer, and they're from China. The family refuses to tell the grandmother this news, which is the cultural standard in China, but in stark contrast to how North Americans approach breaking bad news. And this is the central moral quandary of the film. This is the film we showed. We have a series of films. This is just one of them. The session works by basically you showing the film in its entirety. So residents actually sit and watch the whole movie, and it's framed around a clinical scenario, which involves the main character. We present a case before the film begins, and then there's a brief discussion of how this patient could be managed, and then we watch the film. We interrupt the film once or twice, depending on the film, to illustrate follow-up visits with the doctor. But it's interesting that as the residents are watching the film, they are now much more aware of the story. We talk about afterwards how learning about the narrative story of the patient may affect the way that we handle the patients when they come into the office. So study design was a descriptive cross-sectional study. It was all of the family medicine residents that rotated through FM between October 2022 and January 2023. It was Breer and Primrose. 21 participants took part in this study. Attendance was mandatory, so everyone had to show up. If you were in unit, we got an ethics exemption because it was a QI project. And then there was a consent form for data collection and an anonymous paper feedback form. And we got qualitative and quantitative feedback. The qualitative questions essentially were what were the most helpful aspects of watching the film? What did you like or not like about this style of teaching? Because it's a different way of learning. How can you apply what you've learned to future interactions with patients? What can we do to make this more effective as a method of teaching, and any other feedback? And the quantitative portion was tallied by answer choice, and we calculated median and scores and mean scores, and we used in vivo and directed content analysis to code the qualitative portion. Here's, it's pretty small, but essentially the rating scales showed a very positive response. The list on the left is all of the questions that were rated. One thing that is interesting is, although there was positive response for pretty much everything, the section where it says feel differently about patients after today's lecture, there were a lot of neutrals for that, which was interesting. I'll come back to that in a second. The scores basically showed that the experience was a positive one for the residents in all aspects, and a word cloud was presented of the most frequent responses. This is just an idea of some of the themes that came out. We looked at, they coded to learning points for the participants, positive feedback, practice changing takeaways, suggestions for curricular improvement. The main thing about this was learning about the cultural differences and how that affects the consultation, different perspectives. Yeah, so a lot of the learning from this particular film came from just the cultural contexts and struggles. Narrative content comments included things like I like listening and discussing with colleagues, having opinions of different cultures, group discussion. We get so bogged down with the biomedical model. That was interesting as a comment. They liked the film. The most commonly cited point was the impact of cultural differences and contrasting perspectives in patient care. And the film showed, this is a quote from one of the participants, another culture's perceptions and values around disclosure of serious medical information involving a character of Western upbringing who is relatable. So the conclusion of this project was that teaching medical humanities through film and group discussion provides opportunities for residents to refine humanistic and psychosocial aspects of family medicine in a safe environment. So we're going to use that to try and improve these sessions. The second QI project is about Ballant groups. And I also want to give a shout out to Dr. Beardsley, who is my Ballant co-leader. She and I ran the groups. Also Dr. Leonard Bloom and Dr. Cleo Mavropoulos, who would fill in for us when we were absent. If you don't know what a Ballant group is, briefly here's the short, the quick and dirty. It's a group of 6 to 12 doctors with 1 to 2 leaders that meets regularly, usually for 1 to 2 hours. It's continuous, so it continues to meet. A case presentation is made of dealing with a challenging encounter, and the group explores the case from the perspective of the doctor-patient relationship. And in the residency program, all the residents at Bruyere, Primrose, Civic, and Riverside, Montfort also do Ballant. It's mandatory. It's during block time, and it's usually monthly. And the groups tend to be stable due to cohort matching. The project aim, and this is just a quote from the project, family medicine residents face difficult encounters frequently. They're expected to manage these effectively and empathically, often leading to struggles and dissatisfaction. Purpose of the study is to assess whether Ballant groups increase sense of competence in dealing with difficult encounters. Let's skip that for, okay. So essentially, the results, this was done, I think I've left out the method slide, but the data was collected by questionnaire immediately after the sessions. It was done on SurveyMonkey. Ethics approval, we got ethics exemption because it was a QI project. Again, the first part was just general, whether this met learning needs on a general basis, canned meds for curricular goals, and the general experience. It was essentially very positive. Ballant specific questions were about whether it provided an aspect of training which was not addressed elsewhere in the curriculum. It was important. Whether you feel differently about your patients. Again, the same kind of response as the previous project. Many did, but some didn't. Otherwise, participating will help me take better care of patients. The group helped me to feel I was not the only one, et cetera, et cetera. So I'm just going to quickly go to the narrative. I will look differently at how I feel about the relationship between doctor and patient. So these are comments, very typical. I will consider critically appraising the social context of my patients, my own preconceived notions of beliefs that I carry with me, multiple factors that go into a patient situation. Now, balance groups may not be suitable for all physicians because of some of the difficulties. You do have to be vulnerable in front of your peers. And also there is one of the characteristics of balance is there's often no case resolution and no solutions, but that's part of that. And basically the conclusion was we found most residents believe balance groups are helpful and would be open to participating in future practice. They reported increased self-awareness of their own biases. It was a safe space. It helped some participants develop valuable tools that can be applied to future difficult interactions. Such tools will likely reduce mental workload overload. Fundamentally, it would be tremendously useful for residency programs to incorporate balance groups within their curriculum. So one of the other things that was important about this project is in Canada, although balance groups are used internationally in residency training, we are the only program in Canada that runs balance. Now, back to what I was talking about before, the thing about both of these projects is that they exemplify and demonstrate the importance of thinking divergently and using inductive reasoning. This is basically what we are trying to promote when we do these sessions in the behavioral medicine curriculum. They emphasize the importance of narrative, emotion, understanding the context to promote the role of generals. These are my references. And I have time for questions. I whizzed through that. I'm sorry. It was a bit fast, but I'm happy to, let me stop sharing.
Alan, thank you so much. That was great. And a big congratulations to you and to your residents, you know, for both those projects. If you don't mind, we do have lots of time for questions today. We just have the one presentation for Grand Rounds this morning. If you don't mind, I'd love to start off the question.
What I will say, I have to go to the orientation in about 5 minutes or so, but I'm very happy. I've got at least 5 minutes. So
okay.
Yeah.
All right, then. So we've got 5 minutes for questions. If you don't mind, can I start off with a question?
Yep.
It goes back to the spiral curriculum, Alan. And you explained it very well. I just had a question around the about the progression from beginning, where you start off with basic, arguably normal conditions, to the more complex, more abnormal. And in a generalist curriculum, would it be fair to say that it's really hard to start necessarily at the basic, because arguably with every patient, there is a level of complexity, or as you mentioned, you know, the wicked problems.
Yeah.
Even in these examples that you gave, like of the movie, right? And with balance group, you are struggling with these complexities.
Yep.
I'm just wondering, you know, if you have any comments about that and how that best fits, because I'm a huge advocate of Ron Hardin's work and the spiral curriculum for sure.
Yeah, no. So for family medicine, again, when residents enter the program PGY1 early, and I remember when I was a resident as a PGY1, I was obsessed with not killing anyone, and I really just I was biomedicine. The consultation was something that was a nice to have, but I never really got it until after I graduated, really. Although certainly in my residency, they were teaching this. So, but it's important to lay the groundwork that when you have a consultation, you need to understand how it works. You know, why do I run out of time all the time? You know, how come I can't deal with 5 or 6 problems, you know, but my preceptor seems to be able to do this. All of that is stuff that as you go up the spiral, this is where you learn how to do that. But the basic is basically how to consistently have a patient-centered approach when you see a patient and manage the medicine, because it goes without saying, you need to know your medicine. You need to know your medicine well in order to do this. So patient-centered, then, the challenges are, what do you do when an angry patient comes in? Like, that could be a bad consultation. I can't motivate my patient to stop smoking. What are the tools? So these are all of these things go back to the consultation. Everything goes back to the consultation, which is the tool. The consultation is the tool. I don't know if
that's great. Thank you.
Yeah.
All right, I'll open the floor to others and comments and questions.
That's great, Al. Thank you so much. Very interesting as always. I guess I would ask, do you think that, I know that you are a big proponent of the 3-year curriculum, which of course we're not getting. I mean, do you think that there's enough time to teach this, in our residency? I had not seen this sort of spiral curriculum, this actual description of it. It's very, very interesting, actually, very interesting thought. But, I wonder if there's enough time to kind of start off sort of almost like with the basics and then get a sense of really getting it more deeply.
Yeah.
Do you think that our residents kind of get it by the end? I'm not sure.
So no, that's an excellent question. And one of the reasons I presented this is just to say that this knowledge work, this having to learn to think inductively, as well as, because we definitely need to think hypodeductively when we're dealing with problems, but family medicine is more than that, right? It's actually the whole person. So, and there's been a lot of discussion about how much time you need. I am of the view that let's just say it's very challenging to do this in 2 years. I think, what worries me is I think residents will find this work quite difficult. And then they'll either plod on and these are the ones that end up becoming generalists, usually through trial and error, after in their first 5 years. Many will say, no, this is way too hard. I just want to do focused practice. Or now there's some that wanted to do focused practice in the first place. But, so I think one of the things we have to think about college really as well is, and we need generalists, is how can we get more generalists? One of the things that's important is we need to train them to think like generalists. So knowledge work is all about thinking like a generalist. And that takes time because it's very heavy, it's emotional. There's a lot of intellectual rigor that goes into this. And I would say we probably need more time to do that. That's my opinion. But
okay, thank you. Fabian.
Good morning. Thank you so much. A fantastic presentation. Just my perspective, in Australia, we have rural generalism as an additional training for family physicians. And the total training time is about 6 years. So you cannot do this in 2 years. I loved your talk. Thank you very much.
So so disclosure, I'm an IMG and I trained in the UK, and I did basically 4 years postgrad before I could say I'm a family doc. So I have a certain perspective as well. I do think the thing is now there's like the job is much more complex than it used to be. Multimorbidity. We're running out of generalists, so access is an issue. We don't value continuity like we should, because the doctor-patient relationship and continuity is so. This is the challenge for me as the behavioral medicine lead, is to try and keep these ideas at least alive, because there's many competing priorities that residents have. They do have to learn medicine. They do need to learn focus. They do need to know about diabetes, hypertension, everything else. But it's a tough job. I think it's a fantastic job still, despite despite its challenges. But yeah,
Hi, Alan. Thanks a million for that. That was very enjoyable. I couldn't help not make some comment. I think there are two things. One important thing is the question of our own satisfaction, because I think that where there is good continuity, it adds a tremendous pleasure to being a family doctor. The other thing that's interesting in the CMAJ, I don't know, just this month, there was this article about what characteristics prevent patients being sued, doctors being sued. You know, and it had all to do about sort of the communication and the relationship between patients and physicians. So I think that I thought that was quite an interesting article. I mean, it was focused on the medical legal part, but it has all about how we can practice good medicine.
Yeah, no, thanks, Leonard. I think one of the things is there's often a perception that behavioral medicine is fluff or soft, but in fact, for that very reason, it is crucial. Well, it helps you with diagnosis, because if you are listening to the patient, you will almost certainly have an easier time to work out what's actually wrong. But all of these skills, consultation skills, and the whole way of thinking, the perception is not a soft skill. It is something that is vitally, it is as part of how we should be training family docs. But the pendulum is still in the biomedical kind of camp. I think it's I totally get it. I know how I felt when I was training. So it is developmental. The key, it begs the question: how much time do you need? So that is a.
Just to add one point very quickly, that we tend to think too about sort of narrative medicine as being a lot about finding out about the patient's experience, where they're at, their life, etc. But it's very interesting, even on a very practical level. For example, there was a pathologist who said, I want my residents to do narrative medicine because I want them to look not only at the slides, but to consider the CT findings, just to look at the broader story in that sense. And it was very interesting. Even yesterday in the clinic, we had a patient who came in with query mastitis, query blocked ducts. And when you started to hear about how the baby was feeding, and that overnight the baby wasn't feeding as well, so the breast was becoming more engorged, etc., it gave a clue to okay, this fits with sort of the idea of a blocked duct. You could easily have taken that history without that little detail. It was only in discussion with the patient that aspect of what the nursing pattern was like. And that's narrative too, it's a matter of taking, because initially none of that came out. So it's a matter of taking the time to say, okay, I want to know all of what's the story, what's going on, that gives you, as you said, a clue to the diagnosis.
Alan, big thank you for your presentation today. Great discussion as always, folks.